Assalamu alaikum and welcome to the Medical Black Book. Our today's topic is
Arterial disorder. The first arterial disorder which we are going to study is arterial occlusion or stenosis. This is defined as the process in which there is narrowing of the blood vessels. Due to this narrowing, there is a restriction in the flow to one respective organ, or it can either be a tissue as well. This phenomenon is caused by various processes that are going on in the body. The first process which we are going to discuss is atherosclerosis. In this, what happens is there is narrowing of the arteries, which is due to buildup of plaque. This plaque formation is caused because of the trauma to the tunica intima. When there is trauma, there is deposition of cholesterol, fatty substances, or other cellular waste present in the blood in this tunica intima, which later on, after sufficient amount of time, this solidifies. This condition only affects the large and the medium-sized arteries. Then the next disease is arteriolosclerosis. This is a similar one, but it only affects the small arteries and arterioles, which carry or impart nutrients to the cells, such as the coronary artery, which imparts nutrient to the cardiac tissue. Then we have is Monkey-Burke arteriosclerosis. This is calcified sclerosis that usually occurs in the elderly, affecting their extremities the most. Now, in this picture, this disease affects the media of the arterioles. So, similarly, you can see purplish and bluish calcification present in this arteriole. Then is hyperplastic arteriolosclerosis. This refers to typical arteriosclerosis that affects the large and the medium-sized arteries. Next is hyaline arteriolosclerosis. This is due to the deposition of hyaline in the arterioles, hence resulting in hyaline arteriolosclerosis. This condition only affects the small arterioles and arteries. In this picture, we can see the nephron, which is considered as a small arteriole. Now, this condition can be either acute or it can be chronic. In acute, the most common cause of this arterial occlusion is thromboembolism. The source of this embolism, it can be from the left atrium during the process during atrial fibrillation, or it can be from the mural thrombi after myocardial infarction or vegetation on the heart valve. The symptoms of this disease can be remembered by 4 P's. It is P, 1 P for pulse, pulseless, pain, paralysis, and pallor. If the ischemia is prolonged or is beyond 6 hours, this process is irreversible. The patient comes to us and presents with no history of claudication. Claudication is a cramp-like pain on walking. This is not present on the first step, but it is relieved on standing still. Then we have severe pain, numbness. Pulses are absent distally, but before that or prior to that, they are thrushing, and the distal area becomes cold and molten. Now, the common example for this is acute mesenteric ischemia. In acute mesenteric ischemia, there is severe abdominal pain and bowel emptying is increased, and hence the patient results in increased form of vomiting and diarrhea. To diagnose this condition, what we need to do is we need to do a laparotomy, and in order to treat such an area, the thing is when your bowel becomes ischemic, you do not have sufficient amount of time. So this is basically an emergency. So if you find dead bowel, you need to immediately resect it and remove the embolus which is lodged into the vessel by embolectomy. And after some time, after 24 hours, you have to do a secondary laparotomy to relook if you have missed any dead bowel. Chronic arterial occlusion is caused by any of the above causes, but it is a feature that is present for a prolonged period of time. It could be for months to years. The symptoms include intermittent claudication, which means a cramp-like pain that is present on walking. It is not present on the first step, but is relieved on standing still. The pain of claudication is felt in the calf because of the involvement of the superficial femoral artery. This is present in 70% of the cases, whereas in thigh or buttock, claudication is due to the occlusion of the arterioiliac blood vessel. This is present in 30% of the cases. This is also associated with sexual impotence, which is also known as Lehri syndrome. Now, the resting pain are exacerbating on lying down or lifting the leg up. So the patient usually put the foot down on the floor at night. Now, next is ulceration and gangrene that can be easily caused when the blood is not properly supplied to the respective area. Slowly with time, it necroses. Then the color. The color, temperature and sensation and movement. In an acute limb, the color is white and the temperature is cold and the leg appears paralyzed. But in a chronic condition, as collaterals are made, so the limb acquires the temperature of the surrounding and it almost appears normal. Next is arterial pulses. Arterial pulses are absent in the acute case but present in the chronic case due to collaterals being made. Then the patient presents us with different types of, um, um, with respect to different occlusions of different areas, the presentation is different. If the carotid artery occlusion, there is transient blindness and loss of sensory and motor conditions. So the treatment should be carotid endarterectomy. Whereas in mesenteric, there is pain felt after eating and there is associated with weight loss. Treatment should be enterectomy and bypass. In subclavian, the first part of the subclavian, when it is occluded, when the now there is a specific disease called subclavian steel. What happens is when the first part of the subclavian artery is occluded, when the person exercises, this he goes into syncope because of the reverse of flow into the vertebral artery. Now, how do we investigate the patient? We investigate the patient by general investigation. First of all, in this general investigation, it includes CBC, measuring the glucose level, lipid profile, urea, electrolyte, high blood pressure, viscosity, and ECG. The next is doing the Doppler ultrasound of that respected artery. In a normal artery, there is a triphasic appearance. I don't have a picture of it, but the thing is, if you look at it, there is a triphasic appearance when a normal blood is flowing. So the Doppler basically helps us to tell about the moving blood. That indicates the blood flow is sufficient in that limb. Then the next is ankle brachial plexus. This is a technique in which it is similar to the normal phenomena of taking blood pressure. We take the blood pressure of the normal upper extremity as well as the lower extremity, and we divide the highest ankle systolic pressure by the highest brachial systolic pressure. The normal ABBI should be equal to 1. In claudication, it is equal to 0.9. In resting pain, it is 0.5. And in imminent necrosis, it is 0.3. Then next we have is duplex scanning. It is similar to that of Doppler, but it is more efficient. It provides images of the vessel. Then next we have digital subtraction angiography. Now this helps. This tells us even a more detailed picture by subtraction the artery at after in every millimeter. But the hazards of this is that it can result in aneurysm formation, hematoma, false aneurysm, thrombus formation, arterial dissection. It is not possible to scan the intrathoracic artery because it produces a poor image of arterioiliac segment. Then how do we treat it? Treatment of acute arterial occlusion is by giving 500 units of heparin in IV to stop the progression, and intra-arterial thrombolysis takes about 24 hours to complete. If we do not want to do this, we can either do thrombolectomy, which is a surgical procedure, and to later on, after some time, to assess the patency, we can do an angiography. Note that whenever you do these sort of procedures, if the artery is being previously occluded, when it suddenly becomes occluded, there can be a condition called a compartment syndrome. A compartment syndrome is when you revascularize, there is edema occurring in that area because the capillary permeability increases in such areas after some time. So what happens is that edema will cause pressure on the muscles, which will result in pressure necrosis of those muscles. As these byproducts would be secreted, such as muscle myoglobin, this would cause an increased pressure on the kidneys itself, which will, as the kidneys do not filter such protein, slowly this patient will progress into renal failure. In order to avoid such a thing, we do urgent fasciotomy. The treatment of chronic arterial occlusion is, firstly, we do a non-surgical technique, which is, in general, we include no smoking or exercise. In drugs, we can give antihypertensive statins and aspirin, and transluminal angioplastic stenting. Now, in this process, what we do is we insert a balloon catheter and inflate it. Similarly, we relieve the obstruction. These processes are basically of two types. It can be either percutaneous or transluminal. Now, the side effects of this procedure is basically failure, or it can result in thrombosis, hematoma, or embolism. Now we move towards surgery. In surgery, what we can do is we can do an arterial bypass of the vessel, in which there is affected area is bypassed by the help of saphenous vein, or saphenous vein graft is the best graft that we can use, because the body does not react towards it. So this graft cannot be rejected. Or a synthetic graft, which is known as a Dacron graft. Now our next topic is gangrene. Then gangrene is basically death of microscopic portion of the tissue, which turns black because of the breakdown of hemoglobin and formation of iron sulfide. So basically what happens is that when the blood, when there is a lot of stasis of blood and it does not return, and there slowly necrosis is going on, so the blood hemoglobin breaks down and it imparts a blackish color. This is similar. This is very commonly seen in diabetic patients, which is also known as wet gangrene, depending if the limb is affected by bacterial infection, or dry gangrene if it is not affected by any bacterial infection. So our next class in gangrene is divided into two: dry gangrene and wet gangrene. So how do we separate the gangrene from the normal area? The separation is because of the adequate blood supply. When the blood supply is given to the rest of the limb, there is a granulation tissue formed between the dead and the live area, which separates it. Hence, before surgery, it is easy for us to remove this area, because this area, there is fibrin deposition, so this area can be clearly demarcated. The treatment of gangrene removal is amputation. This is done when arterial diseases causes infarction to the tissue. So in amputation, you can see, first of all, the surgeon demarcates an area, but this is after done. You have done Doppler and duplex, so you know that there's no infarct in the rest of the vessel. Then after you have done this, you make a clear demarcation between the healthy area and the dead area. And similarly, in you with the bone drill, remove the dead area and suture the rest of the limb that can be salvaged. The indication of amputation is basically, can be a deadly limb, or the limb is basically dead lost. So the deadly limb is wet gangrene. You need to urgently cut that area, or spreading cellulitis, or AV fistula is being formed, or a malignancy has occurred there. In a dead loss, there is severe resting pain and ischemia and paralysis. Types of amputation are basically of two types. It can be either below knee amputation or above knee amputation. In a below knee amputation, the joint is preserved, so the person can use an artificial joint and still continue the walking. But if it is above the knee, this is usually done when the femoral pulses are absent and the whole limb cannot be salvaged. Then the person normally uses crutches. Thank you.